So this part of our agenda is slated as a panel on where we are right now with the COVID-19 pandemic, but also any questions that you might have for presenters that have already gone, or anything that you might be particularly interested in with our presenters. So we have Dr. Miller is back, Dr. Smith is back, Dr. Hong is here. We are also joined by our two presenters for this afternoon, so I will very briefly introduce them so that everybody knows what kinds of questions can be asked for them. We have Dr. Scott Olewiler. He is the, let's see, how much of your bio do I want to give? We'll put it this way. Dr. Olewiler believes in the value of a careful history and physical exam over the use of technology. He has special interest in dermatology and the skin manifestations of disease, and which is very interesting, has kept a photographic library of interesting cases since 1996. He enjoys the wide breadth of the variety of infectious disease consultation and enjoys solving the puzzle of every individual's case. We also have Dr. David Weber, who is on the faculty of the University of North Carolina at Chapel Hill and has been there since 1985, where he is currently the Charles Addison and Elizabeth Ann Sanders Distinguished Professor of Medicine, Pediatrics, and Epidemiology at the UNC School of Medicine and UNC Gillings School of Global Public Health. Dr. Weber serves as an Associate Chief Medical Officer and Medical Director of Infection Prevention for the UNC Medical Center, and he serves as the Medical Director of the UNC Program in Infection Control and Epidemiology. Dr. Olewiler is going to be discussing travel medicine and the impact of COVID-19 in the afternoon, and Dr. Weber is going to be discussing pandemics and the global response. So that's who your panel who your panel consists of right now. And I'm happy to open the floor for any questions that may be happening. But until we get some from our audience, I have one for you, and I'm sure that you all have gotten this question a lot, and this doesn't go out to anybody in particular, but I'm interested to know, I want you to predict the future as of this moment. Don't worry, I won't hold you to it if, you know, we get variant Zeta or something next week. What will life look like in a year? Are we going to, we're obviously not going to go back to normal, but what will normal look like? Anybody can take it. Who wants to be brave?
I'll take a crack at that first. This is David. First of all, SARS-CoV-2 is now endemic. It's not going away. We increasingly have a world in the United States split between immunized people, fully immunized, many of them already boosted, others soon to be boosted, who will also have their children immunized in the next few months, probably all the way down to 6 months, and 20% of the US population that will remain totally vaccine hesitant and unimmunized. As all of us are seeing, almost all our patients in the hospital are unvaccinated, and virtually all the deaths are unvaccinated. My percentages at my hospital for floor, ICU, and deaths are 85, 95, and 98 unvaccinated. Just as importantly, the ones who are vaccinated in the hospital, more than 2/3 of them are organ transplants, active chemotherapy, or high-dose steroids. And I'm sure if we broadened out that group, it'd be even more. We know that natural infection provides short-term immunity, and even when it's compared to fully vaccinated, let alone boosted people, fully vaccinated people have 5 to 10 times lower risks. We know Omicron, that having Delta variant doesn't protect you very well against Omicron. So we will see continued substantial numbers of people unvaccinated coming into our hospitals and dying for months to come. That's the first issue. We know that 20 to 30% of at least adults who have COVID, even asymptomatic or mild disease, have long syndrome. We've taken care of over 600 people. Active people are in our clinic right now with long COVID. That will last for months to years. As Dr. Smith knows, kids will be suffering from mental health problems and learning issues from being out of school for substantial periods of time. That will go on for a prolonged period of time. And we know masks work, and if you're vulnerable, that's the one way to protect yourself, but we know it's going to be increasingly a political issue. And of even more concern is we're seeing movement in some states, not only to repealing or not allowing COVID vaccine mandates, but to repealing vaccine mandates for mumps, measles, rubella, and other diseases. And it'll be a lag period of several years before we see major outbreaks, but we potentially in 3, 4, 5 years will be seeing a recurrence of those diseases. On the good news part, again, the companies that do vaccines and monoclonal antibodies will be able to make new vaccines for variants, and so that group will be increasingly protected. And I do expect we'll have better treatments for COVID, so it'll be a disease of the unvaccinated. So those are my predictions. In January, February, I worry and predict a twindemic of increased COVID and flu.
I think this is a fascinating question, in part because what has struck me, I think, most about this pandemic has been its unpredictability and how this virus has sort of broken all of the rules that at least I and many in the medical world had sort of constructed around the way that viruses and pandemics and stuff work. And so, I couldn't believe that we weren't seeing any childhood viruses at all for many months last year, right? The masks made flu go away, made RSV go away, made rhinovirus go, for the most part, go away. Like, we weren't seeing so many of our typical childhood viruses. Children's Hospital was a ghost town. Then, I was like, last year when people asked me to predict this year, I was like, oh, well, so we're all still going to be wearing masks, and so it's still going to be a ghost town. And of course, that changed, and people aren't wearing masks or not taking it as seriously outside of schools, maybe as they do inside of schools. And we're seeing everything come back at higher numbers than we've ever seen it before. RSV, flu's coming back right now. And so I hesitate to make predictions about the future, just only because, I agree with everything Dr. Weber said, but it's just nothing follows the rules. There's going to be a new strain, our vaccines aren't going to work, or there's going to be a new strain that's so mild and doesn't kill anybody anymore that and it predominates, that all of a sudden it becomes not a worry. How are we going to predict that? So, I caution us on predicting too far ahead, but I'm interested what Dr. Olewiler has to say.
Yeah, I'll mention from the treatment standpoint, I'm a real optimist. I was there on March 20th when we had our first case at my hospital, which was tragic, March 20th, 2020. And to think about how much positive our outlook has come from that point, when we really knew nothing what to do. Everyone told us not to use steroids. We've now advanced to the point where we know how to use steroids, we know how to use IL-6 inhibitors and JAK inhibitors. And another glint of optimism that Pfizer is in phase 3 trials for a protease inhibitor with Reitanovir. We've been waiting for this because I think, I believe that the reason remdesivir has had minimal to no benefit is because it's intravenous, that you're trying to give it to people when they're admitted on day 8 of illness, they're short of breath, they're going a high flow, and that's too late for a viral option. So when we finally have a good oral option available, like we do for influenza, something that could be given theoretically in the first 48 hours of symptoms, I think that's going to make a very big difference, will prevent that downslide into the inflammatory phase that really kills people. So I share the other faculty's opinion that I think we'll eventually have a vaccine that you'll need to get once a year. It'd be nice if it were rolled into the flu shot. We have a dual valent vaccines, but I think the treatment will get smarter and smarter as time goes on. Yeah.
And really, the only other thing to add to my my esteemed co-faculty here are, we talked about masking briefly, and I will say just a brief note. So Dr. Weber and I are literally right down the street from each other. It's nice to see you in Delaware, David. We work on the ABC Science Collaborative, which is a partner between Duke and UNC and 50 plus districts, school districts across North Carolina, now expanding nationally, and kind of trying to understand the best ways to keep children safe. And I think this masking is important. So I predict in a year, I'm still going to say masking is safe and effective and the best way to prevent disease in children who are, too young to be vaccinated and, too young. There's one monoclonal now that just last week was given an EUA for use down to birth. We don't, I don't think the oral options for COVID forward coming, but it's still, but I think masking is still the best way to prevent kids from getting sick. I don't see masking going away in our healthcare setting. Schools has been really challenging. Every state's different. And our group, there are parts of the country and districts that are a little bit more COVID adverse, where I don't see masks changing at all in the school year. Fortunately for me, my child's school district is one of those. I see areas of the country and areas within our state and even kind of counties that are next to each other where people are tired of the mask. So I think while I'm optimistic about a vaccine and the therapy, I think the masking issues are not going to go anywhere. And personally, I'm supportive of them.
To chime in, this is Rick from Public Health. So from a public health standpoint, I think that more people are aware what public health does. I think people had a decent understanding of what public health's role is, but I think now that we've been on the front page of everything for the past year plus, that I think people are more attuned to our role as public health. Also hoping that with the attention with public health that we'll receive more resources and funding from the federal level. Most public health departments were under-resourced prior to COVID, and given all the funding available, our goal within public health is to expand our capacity and capabilities and to make it a stronger health department for future events. I think everyone in the state should benefit from that, and every citizen in this country should benefit if public health resources are increased. I agree with infection control. I think that this was an event that we will all remember, and I think this will permanently impact how we do things, whether it's healthcare delivery, whether it's just routine in the streets, in homes and schools, for a long time, and hopefully that we've learned a couple things. I think we have become stronger as an entity in general. I think the medical community was stronger. I think our professional relationships are stronger as well too, and I'm just hoping to see a lot of benefits as a result of this outside of COVID.
That's a really great segue to the next question I have regarding how the COVID-19 pandemic has informed and changed the way that you all do business. It's kind of a two-part question. How do you think the pandemic will inform going forward how you do business? And part B would be, how would you like it to inform? So what do you think will actually happen? But if you had 3 wishes and a genie, what would you like to have happen in your business because of the pandemic?
Well, I'm not sure if this is where you're going with this, Kate, but the first thing that came to my mind, and I'm happy to kind of circle back after my my co-speakers go, in terms of like kind of the business and book of trade. I think we've gotten much better at telemedicine, and in general, I'm a silver lining type person. So like, what can we learn from COVID? What worked well? What didn't work well? I think are there things that we can do to kind of reduce healthcare costs, reduce people coming into the hospital, doing things that we can kind of do remotely that we learned how to do in COVID? So that's kind of an easy, probably not non-controversial answer. But in terms of things that I've learned from COVID is how to maximize, telehealth.
I think one of the things we're learning now nationally is the repercussions of COVID on the workforce, and the implications as far as well-being and burnout. The fact that everything is just a little harder now than it used to be, right? And just from the pediatrician's perspective, take aside from the fact that we all have to wear masks, and just that alone means everything is different and a little bit harder. But like, common cold used to be our bread and butter, right? Easy. Somebody comes with a cold, really easy for us, right? No longer, right? That so much harder. Right now I have to wear all kinds of stuff. I probably have to send a test. I probably have to have staff following up, whether I do the test in the office or somewhere else, following up the family. A lot of counseling has to happen. My staff, every time they take a call or schedule something, they have to ask so many more questions in order to make sure they bring the patient in a safe way with the right PPE, or keeping them home if they're at risk for COVID or what have you. I mean, just there's so many layers that have been added on to all of our practice. And I think it took a while, and we're still doing it, still sort of adjusting. The workforce has to adjust. There probably has to be more people. And right now we have less people because, you know, people got burnt out and people have left, and it has, you know, reached a critical point in, I think, a lot of healthcare systems across the country. And so, you know, looking forward, it means we have to value our staff and our providers and our docs in ways that we didn't before, right? It means investing more in them. It means understanding workflows are different and supporting people in different ways. And so for me, I think that's probably one of the biggest challenges going forward, is figuring out how to make our workforce and their well-being appropriate so that they can remain engaged and satisfied in our field, despite how hard things are right now.
Dr. Weber, if you're speaking, we can't hear you. Now you're muted again.
Okay, thank you. I was going to say that even though we're in the midst of a pandemic, it's not a question if we see another one, it's only a question of when. And much like I hoped maybe the 1918-19 pandemic taught us a lot of lessons, I hope this pandemic teaches us lots of lessons. There are clearly bills, actually, with both Democrat, Republican support pending in Congress to provide long-term funding for future pandemic planning. We did a number of things poorly. We didn't really have a coordinated response. We were slow in developing and using the authorities that were given to the president to develop the adequate personal protective equipment, to distribute adequate numbers of testing, which still remains a problem now. And we'll have a lot of concerns in the future to deal with, including science denialism, politicalization of the pandemic response, vaccine hesitancy, and resistance, as we're seeing with Omicron, potentially more variants in the future that either escape from therapies, vaccines, or more transmissible. But that said and done, I hope as this winds down, we will have lots of us, both individually in our hospitals and across the political spectrum, a discussion of what we've done right, what we've done wrong, and what we can do better the next time around, because there will be another time.
Thank you for that. Go ahead, Dr. Hong. Do you want to add something?
Yeah, I agree with everything that's said right now. You know, can't waste a good crisis, and we've learned a lot through this. And I agree that, you know, unfortunately, we will expect another pandemic, hopefully not anytime soon, but that we will have a higher level of preparedness with processes, procedures, and also just experience in general. I do want to put something out there about mental health. This has been impacted, you know, physically as well as mentally. You know, talked about mindfulness a little bit during my talk, and talking about emotional well-being and self-care. And this might be a change of the way we live in the near future. You know, mental health has always had some struggles. Hoping that we will see some positive out of that after this.
Thank you. So question for perhaps Dr. Hong, perhaps Dr. Olewiler. Dr. Olewiler, I don't want you to feel like you're going to, you know, talk about something that you're already going to talk about in your presentation, but there is a question. What do you think is the threshold for reimposing travel restrictions for domestic travel? Do you think there is one now? What do you think?
I guess I'll start off. You know, answered a question earlier about mask mandates within the state. You know, travel restrictions. You know, with my interactions at the federal level, I mean, everything's being discussed. In terms of triggers, it's really hard to say. You know, trends are critical to find out what's going on. You know, Omicron may have a bigger impact depending on what we're seeing. So hard for me to predict if there are going to be travel restrictions. We did see some of that earlier on. Again, based on lack of information, we're not sure what we're dealing with. Good news is we have more understanding, knowledge, and science behind this. So whatever decision being made probably will have more of an evidence-based approach versus just out of the unknown.
To make a quick comment on that, it's not the travel that's the major risk. I think personally I would favor a vaccine requirement for travel, if only because that'll help increase vaccine coverage as well as add safety. But you know, with modern airplanes, 20 to 30 air exchanges an hour, all the air is HEPA filtered, plus masking. There certainly have been outbreaks on planes, but they're relatively few. It's what you do when you get to the end of the travel. And if you go to, you know, restaurants and bars that are crowded without your mask, if you're unvaccinated, or large, particularly indoor gatherings, then we will see continued risk to those individuals and public health impact of that. So it's not the travel per se, it's what you do when you get to the other side of your travel plans, at least in the US. In traveling abroad, I think the biggest risks are twofold. One, getting trapped somewhere because of travel bans that you don't want to be trapped in. And two, certainly if you do become ill, not many countries have the level of interventions that we have, both with, we just passed our 12,000th dose of a monoclonal antibody at my medical center. You know, not many places will have rapid access to monoclonal antibodies, antivirals, expert, well-trained ICU doctors, nurses, respiratory therapists. So that would impact you if you became sick. Those are the two biggest risks for traveling abroad. In general, I don't think travel bans are going to prevent the spread of variants. They may slow it down a little bit, but we're just as likely to see the next variant arrive here in the US, particularly in an immunocompromised person who can't clear their current virus very well, and therefore there's a selective advantage for a variant.
Thank you for that. I think Dr. Olewiler is remaining quiet because he's going to tell us all about that in maybe half an hour or so. Question from the audience. What initiatives have taken place in Delaware and nationally regarding the management of COVID long hauler conditions? Are there any development of standards of care?
I mean, I'll start with that if you like. There's an excellent CDC webpage on it. To its credit, NIH did pass out more than $1 billion in research grants on this. Fortunately, UNC did not successfully compete with that. But I do think there'll be an enormous amount of more data. I mean, I think the syndrome itself and frequency have been fairly well described now, where we don't know whether there are any interventions that work to treat any of the particular components of it there. But many centers like my own, we have an up and running center. It has 600 plus people we've seen, including some children. It's run by our physical medicine rehab doctors, but there are already pre-described algorithms and referral patterns automatically, depending on patients' need, to psychiatry, psychology, cardiology, respiratory, ID, et cetera, depending upon the individual's need. And I suspect those type of centers will, starting out in the academic centers, grow across the country and ultimately be moved to smaller and middle range hospitals. And I have every expectation, with the substantial amount of NIH funding that has been committed to this, that we will begin seeing papers about potential interventions to better diagnose it and better treat it.
Yeah, I agree. You know, and we're learning more about this in pediatrics as well. Clearly not as well, described. Certainly have a handful of patients, tend to be teenagers, who I will say that we've actually sent to the UNC clinic. It's great. What I love about that clinic is that it's multidisciplinary. And because I think as we still kind of are learning, you know, what services and what interventions work, we often kind of help some of our patients go through this. Unfortunately, it's really it's a post-infectious issue rather than an infectious disease issue per se. So I think ID folks in general are kind of more helping, and in some places quarterbacking. When I talk to other pediatricians across the states, some of the major academic centers do have pediatric kind of long COVID clinics. But I think, as Dr. Weber said, we need to learn more about this. And fortunately, the NIH has invested in just that.
Well, that's good to hear. I'm happy about that. Another question from the audience. Does there become a point that you found of diminishing returns where fear of illness and germs changes humanity and the social structure makeup that is critical? And if you have seen that, what's the breaking point?
I'll take a stab at that one. So I think I'm going to break that into two questions. There's definitely a point of diminishing returns where public health measures are no longer cost effective or evidence based. And so, we're not telling people to wear 4 masks, right? So there's definitely points of diminishing returns, and we have to take all things into consideration. This is not the worst pandemic that humanity has faced. Humanity has demonstrated the ability to be incredibly resilient and adaptable. And I think the folks who are adaptable are the ones who thrive. And so, in my perspective, I don't think that there's a breaking point. If we need to vaccinate and wear masks and physically distance, and we need to do that for months or years in order to safely shepherd ourselves and our families and our society through this, then that's what it means to be resilient and adaptable. And we will thrive.
I do want to just support that comment regarding public health initiatives, and that's something that we struggled. As more effort is being made to vaccinate, initially people were lining up to get vaccinated when there was a strong demand. Now that it's not there anymore. So whenever we make a decision on what to invest in and what initiatives, something else has to go. So as I mentioned during my presentation, cancer screening went down during the pandemic. Some surveillance of chronic illnesses went down as well too. So it's always difficult for us. We want to be good stewards of taxpayer money, resources, that we have to make some tough decision at a time, whether continued effort within COVID outweighs the sacrifice we're being made. So appreciate the mentioning of that, because it's tough. We want to get, every arm counts in the vaccination, but what is the cost of getting each arm vaccinated at this point?
Thank you. How does the appearance of variants affect the prognosis of the pandemic and vaccine efficacy and use? You knew that one was coming.
I don't know that we know. I mean, certainly the Omicron variant's concerning with its some escape probably from fully vaccination, but it does appear that people with a booster of an mRNA vaccine are very well predicted. But when you look at the data in South Africa, it's not clear how much of it is increased infectivity of Omicron, how much of it is escape from monoclonal antibodies or vaccine. There, very few people are fully boosted, so that will provide some. But it also appears to be less virulent, certainly many cases, but no increase in really deaths. So there've been occasional deaths and hospitalizations, but we have a colleague who works there, and they have not seen a major increase in hospitalizations despite a dramatic increase in cases. So each of those are sort of separate attributes. I do expect, given the tens of thousands of new cases every day worldwide, everyone who gets disease is a little incubator for a new variant. So I don't think that they're going to go away. But the solution to that is to deal with vaccine hesitancy and resistance and overcome that. The U.S., when I looked yesterday, ranked 51st in the world in vaccine coverage, and to make vaccines available throughout the world, because, again, we protect ourselves by immunizing everyone in the world there. But I don't know that we can entirely predict this. The Omicron variant, you would think, would arise from just a couple of step mutations, like from Delta, sort of a progressive, but it didn't. It arises from a much earlier parent compound with multiple mutations. So I don't know that it's entirely predictable, but I do believe that the combination of vaccines, therapies, and antivirals will mean to some extent we can largely protect those willing to accept that, and the issue of variants will not be a long-term major hazard.
Great. Thanks. Dr. Hahn?
Yeah, just want to comment, and I'm not an infectious disease specialist, but definitely we've seen how variants or mutations impact other viral diseases. This is the reason why influenza, we get boosters every year. Someone also mentioned that this is becoming endemic, which means that we're probably going to see routine vaccinations or boosters against COVID. It's not going to magically just disappear once the pandemic's over. So, we're always concerned about variants, mutations. Our lab is conducting a sequencing. We are working closely with the federal level as well too, and actually WHO as well, to kind of make sure or track some of these variants of concern. And as you know, Omicron is right now on top of the list at this point. Delta, caused issues. When we heard about this variant, variants doesn't mean that it's going to end up being worse. I mean, right now the Omicron, we're not seeing the acuity, but we still need more data. So it's just part of, unfortunately, the pathophysiology and just the virology of the illnesses.
A question about social media. How has social media and the immediate access to information changed how science is or is not accepted? So what kinds of things have social media platforms done to address COVID misinformation, vaccine misinformation, vaccine hesitancy?
So I'll chime in first. From the Office of Communications, we saw social media as being a friend and an enemy at times. We need to get information out quickly as possible, and especially with how frequently the information is changing, we had to get it out there. We also realized there are groups out there that rely more on social media than any other modes of communication. So we actually expanded our social media, involvement during COVID, we found it very helpful most of the time in sharing information, especially a certain group that does not, as I mentioned before, the younger populations typically that rely on social media than not necessarily the other ways of communicating.
Yeah, and I agree. It's certainly a mixed bag, right? I mean, I probably learned a lot of real COVID information on Twitter that I would not have seen had I waited, for my old paper journal to come, or reading the electronic table of contents like we did when we had time, in the pre-COVID era. So I think certainly a role for it. I think as I mentioned, in my talk earlier, so certainly there's misinformation, and I think social media is a hotbed for, you just need one tweet to be, to be retweeted by a group of people, and you can kind of get misinformation spread everywhere. So that's certainly an issue. But I think the science is the same way. As I said in my talk, there's some science by press release also gets kind of reproduced by social media, and it's not like the anti-vaccine crowd or the anti-masking crowd. Even some of these what those of us at least in infectious diseases kind of understand is a very preliminary kind of one paragraph thing get taken out of proportion. So I think it's important to have, and I try to do this. I don't have a huge presence on social media, but in the last couple of years, I've tried to become more active to kind of correct some information. I think it's pros and cons. I don't think we can blame it for everything though.
I think the issue goes beyond just social media though. It's just the internet in general, and information access has created good sides and bad sides, right? Like our patients are better educated and informed than they ever were before because they have everything at their fingertips, which is good. But they're also not necessarily trained or educated to process that information appropriately. And what has been lost in this is the willingness or the desire to filter that information through your trusted expert, whether it's your doctor or what have you, and I think that's where we've got to sort of find the way to make that bridge that gap, right? Because left without, like, unchecked, somebody going to Dr. Google is going to find whatever they want, right, and validate whatever concerns that they already have in their preconceived notions, and they didn't go to medical school, right, necessarily, and so I think they need some help filtering that. Yeah.
I think it's a really important point. Sorry, go ahead, Scott.
I was going to say just exactly what Dr. Miller said. It's created this huge challenge that there's actually now this big move towards attacking all sources of authority. And unfortunately, the medical establishment is an authority. And people that do a lot of social media get trained that you should mistrust authority. So I'm always challenged by people that come to my office or people I see in my office, sometimes demanding what they want. They want ivermectin. They want high dose vitamin D. Why? Because they read it on social media, and it's really a challenge to take all of your time and try to address those things. Much like the immediate access to laboratory data, which is really harmful to my practice when somebody comes in and says, my MCV was 79 and I'm really upset about it. And something I would never have mentioned, I've got 100 other things to do in my 20 minutes, and now I've got to explain what an MCV is or what the potassium of 3.7 means or doesn't mean. So the immediate access to information has created sort of a race that the doctor can't keep up with. People are getting lab results, they're getting access to things long before we do. So what can I say? I don't have an answer, but it is certainly a challenge. It makes my job a lot more difficult.
All I was going to say was, especially for kind of vaccine and COVID in general, I usually try to provide people with kind of lists of reliable websites. One of my favorite for kind of vaccine hesitancy is, PKids, right, which is not affiliated with, a formal government entity or something. It's stories from parents whose kids had infectious disease issues. So I think there are some ways you can kind of shepherd people in the right direction. There's some really good resources about how do you interpret a website, if on the bottom of the page there's an ad for a personal injury lawyer, please let me know before you believe that. So, but that's critical.
Thank you all. Next question from the audience. To follow up on the telehealth issue, most states relaxed regulations for allowing providers to do telehealth across state lines, and many have since pulled back. Do you think we will see more regional or national licensing compacts that will allow for increased telemedicine access?
Well, I'll mouth off and just say my own opinion because I'm a clinician. I see patients for a living. I think Dr. Smith knows how I feel about eye-to-eye contact and physical exam. There's more than half of the patients I see, the consults I see, they're solved by the amazing diagnostic test of turning the light on and pulling the sheet down. And I can't do that. I can't do a good physical exam over an internet connection. And so in my particular practice, doing ID consults, to me, I think I've done one consultation that way, and that was only to provide vaccines for somebody with a bone marrow transplant, where it was reasonable, just discuss each vaccine and the timing. But for any challenging problem like a fever of unknown origin, I just can't do it that way. So in terms of real hands-on physician care, I don't see that it has an important place in infectious disease consultation, but I'll yield to the other speakers.
Yeah, so I guess I opened that can of worms, so I'll comment here. Totally agree, right? I'm an infectious disease doctor, and even when our health system was saying, "Hey, keep kids out of the hospital, don't have them come to your clinic," for all new patients, we said no, you need to come in person. But I think, for instance, it's still a win-win situation. If I'm seeing someone like a hospital discharge, who just needs a follow-up in a week, maybe some labs, if they live 3 hours away. I can see them, I can talk to the family, how are things going? I can send them to the lab, with Epic and Care Everywhere, I can still get those labs done. That's kind of more, more what I meant. And again, I think, in the middle of a pandemic, there was a time where it was actually not safe to go sit in a waiting room, so I think, there's the risk benefit. And I think that's just an example of something that changed in the pandemic that is not perfect. I know how it works. I know where it works well, and I know where it doesn't work well. And where it has worked well, we're going to keep doing it in our practice. But totally, don't get me wrong. As an ID doctor, for our new patient consults, we need to see all of them in person. Just to clarify.
Oh, I agree. There are definitely the types of brief follow-up visits that are perfectly appropriate for that. But that's just not a big part of the visits I have to do. So I'm in agreement. Yeah.
But the thrust of that question was, in the context of the pandemic, we had a situation where our laws preventing people from providing state telemedicine across state lines, but preventing us from providing any medicine across state lines, was really prohibitive to matching supply with demand in resource limited times. And like, I hope, I don't know the answer to Dr. Sheehan's question, but I hope that our government is taking that seriously and looking at whatever needs to happen to allow licensing to cross state lines for both telemedicine and for regular medicine.
Excellent, thank you. Another question from an anonymous attendee says, I hear most of the speakers strongly advocating for wearing masks and social distancing. I wonder your thoughts on why then most states, including Delaware, do not have indoor mask mandates or social distancing mandates.
Well, I think this is where, again, the politicalization of public health has occurred. There's no question. There are many, many papers from being in schools, healthcare, et cetera, that masks are protective. And when you can't wear a mask indoors, eating or drinking, then physical distancing is the next best thing you can do. And what's more, if you do both, they're additive there. You know, we looked at our data in our COVID units recently, 1,500 patients, and we had maybe 2 cases of COVID in a healthcare provider where we couldn't absolutely exclude the workplace. Doesn't mean they got it there, but we couldn't prove they got it from a family member or a friend. And we've had many of our healthcare providers get it. So we know masks work, but unfortunately it's become a political issue and not listening to the public health experts. So that's why we're seeing relaxation of mask mandates. It's because a segment of the population would like to see that, and the results are all of our hospitals are filling up again with COVID patients, and we're soon to surpass 800,000 deaths. 1 in 100 people over 65 will have perished with this pandemic, and we're on track by March to have over 1 million deaths of COVID. And to put that in proportion, you know, we lose about 100 people a day from car crashes. They make the newspaper all the time. We're losing over 1,000 people a day from COVID. Just imagine, you know, 4 jumbo jets every day crashing. 1 jumbo jet crashing and killing everyone on board would be front page in all the news and the lead story on every television network. And we're losing 4 or 5 of them every single day, and we have for months. So we've become inured to that terrible human waste, unfortunately.
Just to add to that, Dr. Weber said it nicely. The evidence base is there. We understand what it is. So it's not about that, right? This isn't about what's the right thing to do, especially since a lot of these states are rolling it back like right now. And I think Dr. Reitanovir showed us the chart, like things are getting bad right now. If you're making the decision based on like the current state, you wouldn't roll things back. So this is about this age-old personal freedom versus public good, right? And that's all this is about. And in some states, they are valuing people's personal freedom to not wear a mask over the public freedom to remain alive from COVID. And I think that's become politicized, right? That's a political thing. That, you know, that's not a medical thing. It's not a science thing. It's philosophy, right? I could talk to you guys about like the ethics of it as much as you like, but that is not a science thing right now.
I totally agree with this sentiment, and I'm a little sympathetic to those who are getting mask fatigue. You know, we're working on 2 years now, and asking the public to put a mask on and walk around, you know, buy a box of cereal at the supermarket. It's really asking a lot. I have 5 children myself, the youngest of which is 6 years old, and asking them to grow up in a world without faces. I mean, I'm sure the pediatricians can attest to the real mental health harm that does, you know, the lack of interaction, lack of seeing smiles, human features. So I'm very, you know, we all agree, I think we have to find some kind of balance, because I don't really want to live in a world where I have, you know, a fireman's gear on with full face shield, but I don't really want to partake in that world. So I hope we have to arrive at the right balance.
I appreciate all the comments. I've been in public health since 2005, but not in my state medical director role until 2018, and see the daily struggles of how you balance individual liberties with the public good. And, everything we do, we always have to balance not just the purpose of the initiative or proposed initiative, but also all the other aspects to it, including mental health, including just individual liberties and things like that. I think what my personal focus, whether it's mask wearing, whether it's vaccine, is I want to make sure the individual is empowered to make the right decision, have the right information to make those decisions. We have our own, thoughts. My role is not to impose my thoughts on others, but I feel I've done a disservice to the community if there is not appropriate information out there for them to make that decision. I am totally believe that the individuals should make those decisions. I think if the information is out there, the correct information, accurate information is out there, then I think most people will make the decision that we all hope they would make, especially during this pandemic.
I hope they do too. I don't want to keep wearing a mask, but at the same time, I still go into the grocery store and I'm like, nope, I don't trust you people yet. Let's talk briefly for the next 2 minutes just about the flu. Do we think that the lower than expected flu vaccine uptake is possibly related to the COVID vaccines? What do you think we're going to see as this flu season really takes hold?
So I shared a paper earlier where they actually found that maybe flu interest was increased this year. And I mentioned that anecdotally, I've had a lot of yeses to the flu question this year. But our flu rates at Nemours are way lower than they were last year at this time. And I think most of that, at least for us, has been access. We are having a workforce problem. We can't have the big flu clinics that we used to have in the past. And so we on our side can't do it the same way as before. So I'm not ready yet to say that the decrease in flu is solely because of some pandemic increase in hesitancy, although that could end up being the case.
Yeah, I agree. I think it's a little too early to know what's going to happen. It's not too late to get your flu vaccine, people remember, but we're at least here, and I'm sure everywhere across the country, we've seen more influenza in the past week than we did all of last year. So I think our hospital and our department of pediatrics is getting this message out there to get people vaccinated. And again, I'm not in primary care, but we do offer both COVID and influenza vaccines in our clinic to our clinic patients. And the people who have not been vaccinated, who I've seen, they've all accepted influenza so far. So I'm hopeful about that. And I agree with Dr. Miller. I think making sure you have the access set up and getting the message out there is going to be critical.
I'll reflect something that Dr. Miller addressed earlier today, which, on hesitancy, you still have a large number of people who think the flu shot's going to kill them. So that's a sell on itself. And then there's the people who are sure that if they get COVID, they're going to have their DNA combined with that of a spider and turned into Seth Brundle, if you're a movie fan. So I've had a few interactions with patients who just can't take the cell all at once. They're worried about the side effects from COVID. They don't want to get the 2 shots on the same visit. So I've had some reactions that, all right, well, I'll get that COVID shot, but you got to give me another month or so to recover before I get the flu. So I think hesitancy is a real big issue in my patient population right now. There's another problem, which of course is that last year we basically had no influenza. So people have gone a little bit to sleep on that. They kind of think, well, influenza's gone. Don't have to worry about that one. It's just the COVID thing. And I thought maybe that would be the case this year, but I'm sure because of the fact that we're not wearing masks on our face now, of course, influenza is spreading once again. So we have to wake people up that, yep, flu's back now too.
Before we end, I just want to make a plug for my professional society, Society for Healthcare Epidemiology of America. To me, this has just been a wonderful panel, great and diverse ideas, lots of expertise and very helpful. But Shay, the Society for Healthcare Epidemiology, has a COVID update panel every other Sunday at 3 o'clock. This you can just go on their webpage to link in. This coming Sunday will be panel number 62 or 63, and led by David Henderson, the former deputy director at the NIH Clinical Center, and people who want ongoing information right up to date with a focus on infection prevention, but many other issues. I would encourage to listen into those discussions on alternating Sundays.
Thank you very much, Dr. Weber, for that. And thank you to the panelists, especially those of you who stuck around after speaking this morning. Very much appreciate it. Somebody from the audience said he thinks this panel should be front and center in the national media, and we would have a better understanding and better outcomes. So not much more I can say to that, but thank you all very much for your time and patience and ability to answer our questions.